Good morning, everybody, and welcome. Please come on in and be seated. We're going to go ahead and begin. I'm Bill Weintraub, cardiology, and from the Value Institute. And I'm really thrilled this morning to welcome outstanding speakers for our symposium on care for patients who are post-incarceration. There's a tremendous social need in this area, and that's what we're going to hear about this morning. This symposium is brought to you by the Value Institute and by the Delaware CTR ACCEL program. Let me tell you a little bit about each of these. The Value Institute was created about 5 years ago by Bob Laskowski. Its primary components today are healthcare delivery sciences, which is led by Eric Jackson, and the Christiana Care Center for Outcomes Research, which is now actually over 10 years old, which provides the epidemiologic biostatistical data handling support for much of the work we do in evaluating healthcare and for translational research in healthcare. Very closely coupled with the Value Institute is the ACCEL CTR program, which at least Christiana has managed through the Value Institute, and the goals are highly in alignment. The CTR is an NIH grant overall encompassing 4 institutions besides Christiana, also AI DuPont Hospital for Children, the University of Delaware, and Medical University of South Carolina, funded by a $20 million grant from the National Institutes of Health and an additional $5 million from the state of Delaware. It's been highly successful in doing many things, and many additional grants have grown out of it. And one of the most important things is in community engagement. So here's really an opportunity in community engagement. We also have a set of very large grants within the CTR, and one of the largest, perhaps largest, is what we call the CTR Scholars Program. And we have a really outstanding CTR scholar here in Delaware, in Dr. Leroy Hicks, who I think you all know. Now, Dr. Hicks' grant was really to develop our program for reducing healthcare disparities. You'll know I didn't say studying healthcare disparities. Time for study has passed. I said reducing healthcare disparities. And Dr. Hicks and I have been discussing this at length at our many meetings now for over a year. I became aware, in part because of my many activities related to the CTR, of the work of Dr. Emily Wang from Yale, and became aware of her incredibly important work in post-incarceration care. And I started to talk to Dr. Hicks about this, and he said to me, "Oh, I know Dr. Wang," and we felt that it was just really important to work with her and with people around her to develop our own program in post-incarceration care, because this is a tremendous special needs population. Now, they have a lot of needs, but I'm a cardiologist, and I'm very well aware of their needs in cardiovascular care and risk factor prevention. But there are also problems of substance abuse and violence that really need to be addressed in the special needs population. And I think we found a ready voice in the leadership in Christiana Care for trying to help these folks reemerge into society and receive the care they need. And it's all embracing, as you're going to hear about this morning. So I can hardly think of a more important thing to discuss this morning than how to care for our patients post-incarceration. And so we'll begin the program now. Let me introduce Dr. Leroy Hicks, who will further discuss the whole program.
Thank you, Dr. Weintraub. Can everyone hear me? Okay. I've been told that despite my overwhelming physical presence, my voice is often too soft for people here in the auditorium, and I have great difficulty standing behind a podium, so I prefer to step to the side and walk around, and I just want to make sure I'm completely audible. The interaction that Dr. Weintraub mentioned just now about our early discussions related to post-incarceration healthcare in Delaware and its link to racial and ethnic disparities was much as he described. And it was actually fortuitous timing. About 2 years ago, maybe 3 years ago, I bumped into Emily Wang at a national meeting. That is the academic meeting for our society in internal medicine. And we happened, I think, to get coffee and chat a little bit about the Transitions Clinic Network and some work that we hope to do collaboratively at some point in the future. And upon my arrival here to Christiana Care and engagement in ACCEL CTR and talking to Bill, it really became very, very evident that not only is there a zeal for doing this from an academic perspective, but quite frankly, and more importantly, there's a need to do this from a community health perspective. Our objective as an organization, Christiana Care Health System, is to maximize the human health of the residents in Delaware. And quite frankly, for all our aspirations and all our hard work and all that we've done and achieved, there are still significant gaps in health in our state. And there are groups who are at particular risk for poor health outcomes. And so we hope that today you'll have an idea of some of the models that exist to administer care to a population that's very much at risk. And you'll hear a bit about how the risk of poor health outcomes may be mediated by being previously incarcerated. But before introducing the speakers, I thought I'd give you a bit of motivation by sort of setting things in real life context for you. As Dr. Weintraub mentioned, many of you know me, but for those who don't, I'm Vice Chair of Medicine here at Christiana Care in the Department of Medicine, and I run general internal medicine and hospitals medicine here. But before I got engaged in research and became an administrator, I was a hospitalist, and I still see patients occasionally. I'm an internal medicine doctor who practices on the floor. 3 months ago, I actually was attending on service at our Wilmington Hospital campus, working with the house staff. And there was a patient, and I'm going to tell you about this patient. I'm going to call him Mr. L, who was a 32-year-old male who I went in to see early on a Wednesday morning. Okay? Now, Mr. L, actually, this was his second hospitalization in only 3 weeks. History goes as follows. 2.5 weeks before I saw him, he presented to the emergency room complaining of difficulty swallowing. He had such difficulty that actually it was very, very painful for him to swallow even liquids, and it had gotten progressively worse, this pain with swallowing over the course of many, many weeks. He had gone to the emergency room, sat in the ED where there was happened to be a lot of patients and a prolonged wait time, and he got frustrated and left. And came back to the emergency room a second time, only when he discovered that he just couldn't take anything down because of the discomfort. At the same time, he reported having fevers regularly over the course of several nights. When he was seen in the emergency room, he was profoundly dehydrated, he was lightheaded, and he got admitted to the hospital, where he was cared for by a hospitalist. Now, Mr. L did not have a primary care physician. He did not have a clinic where he received continuous care. And in fact, he was previously incarcerated and had been released from the prison system just 6 months before. And in that time, he had not yet gotten engaged in healthcare coverage. He wasn't covered by Medicaid. He was uninsured. And so this hospitalization actually represented the first real interaction with the healthcare system since his release. Turns out he had an infection of his mouth and his throat that is very commonly associated with HIV. The admitting doctor sent HIV tests on Mr. L. They started him on a medication to help reduce the burden of yeast in his mouth with the goal of having him swallow. When they checked his lab, they actually found that his kidneys were not working maximally. He had the kidneys of someone 30, 40 years older in terms of how they cleared waste products from his blood. But he didn't require further hospitalization. So he got discharged. And the plan was for him to follow up with a GI specialist who would then hopefully take a look down his throat and to follow up in the resident clinic where someone might be able to follow up on his pending HIV test. That resident clinic appointment was for 2 weeks later. And by the time Mr. L arrived, his pain was so significant, despite having the yeast burden reduced, he hadn't eaten anything for 3 days. He was profoundly dehydrated. His worsening kidney function had become that much worse, and he was immediately hospitalized, where I walked into the room to find that he was HIV positive, and he had an overwhelming infection due to a virus that is commonly associated with HIV. We seldom see it this advanced anymore. It was what we call an AIDS-defining illness. And he required intensive therapy, both to get started on treatment for his HIV, but also now for the opportunistic infections that faced him. So why do I tell you this story? Because I think it's important as we venture on throughout this morning and we introduce our speakers, and each gives you a talk about one, how the criminal justice system works and the health care that's administered to incarcerated populations. And then as we begin to talk about healthcare disparities or differences in health outcomes and how being previously incarcerated may play into that. As we talk a bit about the psychological factors and how they impact health outcomes both pre and post incarceration. And as we talk about systems of care that might be implemented to hopefully improve healthcare outcomes for populations that are previously incarcerated, I want you to realize that while all of these things may be interesting, may be important, that we have a real issue right now today in the population we serve. And I want you to understand that what we're talking about here isn't intended to be an academic exercise. Do you understand? It's intended to make very concrete in your mind some of the models behind the outcomes that your very neighbors here in Delaware face, and to promote thinking for us as a healthcare organization about how we might improve those outcomes. So to that end, I'm very thrilled to announce that we have a great slate of speakers coming forward, and I'm going to introduce each now, and I've already warned them I'm not going to do my usual flowing, wonderful 5-minute introductions of each, but instead tell you who they are, what they're going to present, and allow each to concisely introduce themselves as they step up, because we want to move forward with the agenda. I want to first thank Dr. Vincent Carr for stepping in this morning. Another colleague from the Bureau was to present this morning and fell ill. Dr. Carr is medical director of the Delaware Department of Correction, and he's going to talk about navigating your way through the criminal justice system here in Delaware and talk about aspects of healthcare delivery within the correctional system. He'll be followed by a medical officer from the National Heart, Lung, and Blood Institute, Dr. Nicole Redmond, who is perhaps the most overeducated person I've met, as you can see. Dr. Redmond, prior to being medical officer at the NHLBI, which is a job that's now several months old, she was an assistant professor at the University of Alabama in Birmingham and was actually a site participant in the Transition Clinic Network, which we'll describe later. She's followed by Dr. Brita Roy, who is a close friend of mine, and we've worked together on some national committees. And Dr. Roy is an assistant professor in the section of general internal medicine at the Yale School of Medicine and is director of population health. And she'll explain to us, she'll sort of present models for psychological factors in their relationship with health, and will talk to us a bit about how those associations may vary pre and post incarceration. And last, I'll have Dr. Emily Wang, our colleague who's an associate professor at Yale School of Medicine and the primary investigator and co-leader of the Transitions Clinic Network, talk to us a bit about their novel programs, their practices, and some of their outcomes. So I'll ask, as we have Dr. Carr come up, for you to give them all a rousing round of applause, and then I'll ask you to do your job, which is to listen intently, and then please ask as many questions as you have. Thank you. Dr. Carr?